Hello, everyone. So, an interesting case. We just had a patient in his 60s who came in for injury of his left eye. He was working on a lawnmower and a small piece of spring bounced off and hit his left eye. Immediately after the injury, he lost vision in that eye, and he came to us maybe 45 minutes after the injury. When looking at his eye, one can appreciate extensive chemosis, and his pupil was dilated and fixed. This denotes traumatic mydriasis, which can happen due to injury to the sphincter pupillae muscle. The pupil becomes dilated and fixed. And clinically, you can appreciate kind of a reddish hue when you look at his eye, at his pupil, which is not very obvious from the picture, but this further raised suspicion for bleeding inside the eye. So we decided first do fluorescein staining, make sure that he did not encounter any injuries to the outer surface of the cornea as well. And upon doing so, if you look here at the 2 o'clock or 3 o'clock position, there was a questionable sidal sign. And we fluorescein stained him while he was in an upright seated position. And you can kind of see that, the stain kind of appears as though there is some extravasation of material possibly coming out at the, again, 2 o'clock or 3 o'clock position. So this raised concern for a possible globe rupture, and we decided to check his intraocular pressure, which turned out to be 2 millimeters mercury in that eye as opposed to 19 millimeters mercury in the opposite eye. So we decided to treat him as an open globe rupture. We kept him in an upright seated position. We covered his eye with a shield, and we started him on IV antibiotics. We gave him a dose of Levaquin. We sent a page out to ophthalmology, and we sent him to get a CT of his orbit. The CT scan result was interesting. If you look closely, you can actually see that the left eye appeared to be smaller in size compared to the right eye. And you can see what appears like extravasation of material outside of the eye itself. And if you further look closely, you can appreciate what appeared to be suggestive of a retinal detachment with intraocular hemorrhage. By that time, the ophthalmologist was able to call us back. We discussed the case with him, and he suggested that we send the patient over to a tertiary care center where they can perform operative intervention on this patient, and we actually did. And a few days later, I called the patient back to check on him, and he told me that they found that he had 2 ocular lacerations that were repaired. And when I spoke with him, he could still only see light and could not still count fingers. An interesting clinical observation was, upon reassessment, you can actually see that the left eye became visibly smaller in size as well, just by looking at it from the outside, which gives you an idea of how quickly the intraocular contents can extravasate out of the eye following a injury to the eye. And he spent in the ER maybe about an hour at the most, not more than that. So a couple of questions arise from such a case that we can actually learn from. So a question that might come up here is that why did we check the intraocular pressure? The classic teaching is that we should not check intraocular pressure in a case where globe rupture is suspected. Otherwise, we can actually make things worse. And yes, this is true. But remember that the classic teaching is that checking the intraocular pressure in such patients is contraindicated or should be limited. And because this patient was questionable for an open globe rupture, he did not have like a very classic sidal sign. The injury was blunt trauma. It was not penetrating injury. And because we wanted to come up with the diagnosis, that's why we checked the intraocular pressure, and we actually kept it limited. It was checked very briefly. And the other thing that goes along with that is the device itself that you use to check the intraocular pressure. So there are different types of ways to measure the intraocular pressure. One is applanation tonometry, which is also known as Goldman tonometry, which is used mainly by the ophthalmologists in the office with a slit lamp, and it involves direct contact with the eye. Another type is called the indentation tonometry, which we use sometimes in the emergency departments using a tono pen, where you actually go down and also apply a little bit of pressure on the cornea to check the intraocular pressure. Another type is called the rebound tonometry, which is also, known as the eye care device, and it involves, having a small disposable, pin with kind of a round plastic tip to it, and it basically hits the eye very slowly and then rebounds back, and then this rebound technique gets translated into a pressure measurement, and you're able to read the pressure on the device itself. And then the kind of last but not least most common way of checking the intraocular pressure is using what's called the non-contact tonometry, which is the air puff device. This is also mostly available in the ophthalmologist's office, and it just basically involves a puff of air that kind of hits the eye and eventually is detected by the device and gets translated into a pressure measurement. So the applanation or the Goldman tonometry, which involves direct contact with the eye, technically involves a lot more application of a lot more pressure than what we used for this patient, which was the rebound tonometry using the eye care device. So not only that we limited the use, just checked it once, but we also used a device that does not apply the same force as you would expect with applanation tonometry. So this is with regards to answering the question about why did we check the intraocular pressure. We checked it because we needed to rule that out, because once that was confirmed with a low intraocular pressure, our suspicion for globe rupture went up through the roof, and we decided to, things kept moving quickly. IV antibiotics started, a call to ophthalmology was made emergently, because, this obviously is an emergent condition. This is an emergency. The other thing is, a question that commonly arises in these situations by the patient is, am I going to get my eyesight back? And an interesting scoring system that you can use here is called the Orbital Trauma Score, OTS. And this score was established, I think, in the early 2000s. And it gives you kind of a prognostic indication for 6 months after the initial injury. What are the chances that the patient is going to, regain some of his vision back after 6 months from the injury? And the orbital trauma score takes into consideration a few different factors. They are visual factors, obviously, including, the visual acuity itself, the presence of endophthalmitis, the presence of afferent pupillary defect, the presence of globe rupture, and so on. And each one of these categories gets a score, and ultimately, you calculate the numbers together, and you come up with a score of 1 to 5, 1 being the worst and 5, having the best prognosis. And if you look at the table here, you can kind of see how each score, translates into what you would expect to have over the course of, or after actually 6 months from injury. And even though there are more recent studies that have shown that, this scoring system tends to maybe sometimes underprognose or give you a much worse prognosis than what is seen in real life. However, it's a useful tool to kind of, discuss the potential prognosis with the patient. And it is also helpful in, planning for the possible, operative intervention. So it's a very good tool to utilize when counseling patients and when looking at, the possibility for, how aggressive you should be with operative intervention moving forward. So remember that this, is a potential tool that you can use as well to be able to answer that question more objectively. So to wrap up, this was an interesting case. I would say that you should maintain a high index of suspicion when you see any patient with traumatic mydriasis. Know that this is something that can happen, especially if you see, some irregularity in the pupil itself. This should raise your suspicion for checking the intraocular pressure, and before checking the intraocular pressure, actually staining the eye and looking for a potential sidal sign. If you see an obvious one, then assume globe rupture and don't do anything further with regards to intraocular pressure checking. If you see kind of a questionable sidal sign where you're like, I don't know if this is real or not, then it might be a good idea to check the intraocular pressure. And rebound tonometry or the eye care device is okay to use in these circumstances. Just make it extremely limited so that it would guide you further on what you need to do. And obviously, an emergent consultation to ophthalmology here would be important to give you some assistance moving forward with regards to planning for operative intervention versus maybe conservative management. I'll see you next episode.